Welcome, everyone. My name is Daniel Romero. I am an assistant professor at Vanderbilt University Medical Center in the Department of Hearing and Speech Sciences. I feel very honored to be invited here to give a talk about VEMP testing, and we're going to be discussing the clinical utility of VEMP in an ENT practice, lessons learned. So hopefully some of you out there learn a thing or two, and anyone thinking about implementing VEMPs, or what does it all mean? How does it kind of integrate itself into a standard vestibular test battery? Hopefully we answer some of those questions for you today. So as I said, I am an assistant professor at Vanderbilt. 50% of my time is research-based. The other 50% is clinical-based. And so I do see patients half the time as well. Most of my research really focuses on basically understanding the role of the vestibular system and how it impacts, dizziness and balance, and how do we improve the assessments that we use to diagnose a vestibular impairment. Certainly in patients who are dizzy, but also in other special populations such as traumatic brain injury. So I also do that. I also, serve as treasurer on the American Balance Society, and do some work with the American Academy of Audiology. I've also co-host a vestibular-focused podcast, more geared towards students and other healthcare professionals, called A Dose of Dizzy. Here are my relevant disclosures. Wanted to give everyone kind of a sneak peek into what we're all about. We have about 6 audiologists on our balance team at the main campus at Vanderbilt, led by Dr. Gary Jacobson. Now, our standard vestibular test battery consists of a full-fledged VNG, cervical VEMPs, ocular VEMPs, rotational chair, and video head impulse testing. We have 3 different VNG rooms, all with the capability of performing all of these measures. Here's an overview of what we'll be discussing today. So I know many of you are very familiar with VEMPs, on how to measure it, things like that, but I still want to just do a quick little brief overview to get everyone on the same page, just in case anyone out there isn't as familiar. We'll talk about just different common pitfalls encountered when performing the test, then move right into the clinical utility of VEMP testing across a variety of different vestibular disorders, and then fully just kind of bringing it all together, understanding the role of VEMPs in the context of the standard vestibular test battery, followed by some case studies. Now, we're well aware of, many of the different ways to measure the vestibular system, and one of the ways we do that is, of course, through its physiology, sending some type of sensory input, having some central integration, and measuring some motor output. So this is the basic fundamental rationale or fundamental basics to VEMP testing. Now, of course, we're all familiar with how VEMPs work. We're sending some type of sound, acoustic or vibrational or mechanical stimulation to the inner ear, which causes activation of those otolith organs and creates a shearing linear force. The most common accepted theory at this point is the fluid displacement theory, where these otoliths are kind of these hair cell bundles are sort of being activated because of the fluid displacement created by the sound pressure level, or by the sound. And it creates that shearing effect. This is similar, honestly, to, I guess the whole concept of in and of itself is similar to, I like to think of it as the knee-jerk reaction when, this reflex hammer gets, your knee gets hit with that reflex hammer and your knee kind of automatically goes up. I always like to think and tell patients that we do the same thing with sound. That is the basic fundamentals of VEMPs. Now, this is really all made possible because the saccule and utricle are sensitive to sound. And their proximity in the vestibular labyrinth. We know that the saccule is underneath that stapes footplate, and once these otoliths are activated from the sound or vibrational stimulus, that electrical activity is routed to the motor units of the muscle, known as the motor unit action potential. Now, what we've really come to know over the years through the greater minds than myself are just sort of how these otoliths are respond to sound at different frequencies. So here I'm showing the frequency response of the utricle and the saccule from Kurthois 2017. And what you can see is this broad sensitivity of the otolith end organs, particularly the increased sensitivity at low frequencies. So the lower that frequency, the more responsive these otolith end organs um, are activated. And what you can also notice is that the saccule sort of is sort of responsible or responding at a lower overall intensity than the utricle, and this is primarily associated with its proximity right adjacent to the stapes footplate as opposed to the utricle. You know, really much of what we know comes from the work of Bickford et al. In 1964 with regard to VEMPs, where they were measuring from behind the scalp and noticed these myogenic responses that were being produced. And what they really started to see are these sort of two biphasic peaks. But what was most interesting is that when they seemed to push the head forward, sort of contract those neck muscles, they noticed an increase in the response, and they noticed when the patient was in supine or a more relaxed position, the response would pretty much go away. And they primarily described the response as being myogenic. There were some arguments that the response was cochlear, cerebellar, but this sort of provided a basis for um, what we all think as sort of that first paper or looking at CVEMPs by Kolbach et al. In 1994. So this is the pretty much the pathway that underlines the cervical VEMP. It's known as the vestibulocholic reflex. Goes from the saccule up to the down the inferior vestibular nerve to the vestibular nuclei, going down the medial vestibulospinal tract down to the spinal accessory nucleus of cranial nerve 11, and kind of synapsing on the motor units of the sternocleidomastoid muscle creates this contraction. Is known as an inhibitory response. A little bit different from the OVEMP, of course, leaving from the utricle up the superior vestibular nerve to the nuclei, up to the contralateral inferior oblique muscle. This is generally thought to kind of go along the same pathways as the vestibular ocular reflex. Here's just a basic setup of the CVEMP. We have our ground electrode there on the forehead, our non-inverting or active electrode on the ipsilateral sternocleidomastoid muscle, ipsilateral, of course, to the ear being stimulated, and our reference or inverting electrode on typically convention to kind of put it right at the top of the sternum there. A little bit different than that OVEMP response. Instead of the active or the non-inverting is typically on the contralateral inferior oblique muscle to the ear being stimulated, and the reference on the contralateral inner canthus right on the side of the bridge of the nose. Now, really, the underlying process that allows us to detect these muscle changes is surface electromyography. At the end of the day, that's what we're essentially measuring. And so we're essentially measuring these changes in muscle fibers known as the motor unit action potential that is detected by the electrodes. And these responses can essentially be looked at two different ways. We are most familiar um, with these changes being represented across time or across that time domain, looking for this biphasic peak. But it can also be represented in the frequency domain, and there's some newer research looking at some frequency, or at least trying to further understand the frequency content underlying VEMPs. So here's just a simple demonstration of how we're arriving at those clean waveforms, because of course we have to separate that signal that we're interested in, separate the signal from our noise. Through the use of signal averaging. Um, so we're looking for that positive followed by that negative peak for CVEMP, and completely flipped for the OVEMP, where we're first looking for that negative peak followed by that positive peak. And we present this stimulus about 1 to 200 times, depending on how clean that signal is, and we're basically averaging out the underlying noise. We make those waveforms and arrive at those clean waveforms for both ears. This is done across ears. We then take that peak-to-peak amplitude and measure that amplitude and compare that amplitude to determine if there's any significant asymmetry. So we'll either determine whether the response is reduced compared to the other side or just completely absent. There are a number of factors that, of course, can make our signal smaller or can affect VEMP detection. One of them being muscle contraction. We'll discuss this along in just a little bit when we talk about common pitfalls, but just a brief overview about some of the different factors that can affect VEMPs. You can also, which of course, muscle contraction is seen in older adults, so that means that an aging population coming into your clinic, that is going to they're often present with differences in muscle contraction. So something to keep in mind, especially when determining if there is an underlying asymmetry, or just when trying to interpret those findings. Um, Aging really affects pretty much all aspects of the VEMP. It affects latency, amplitude, and response rates. It just also, in general, makes the response more variable. So we're going to get into some of the common pitfalls often experienced during VEMP testing, and many of these come from Rosengan et al. in 2019, but are pretty universal across any aspect of the VEMP. First, of course, being the stimulus level. There's some debate on how high this stimulus level should be. It's common practice to typically stimulate at about 125 dB peak SPL. There's been some evidence, however, to suggest that presenting this high of an intensity level in the pediatric population or in children can result in can lead or at risk for some type of noise exposure. So this level may vary a little bit in children, but in adults, it's typically presented at 125 dB peak SPL. That is important to sort of know the underlying dB peak sound pressure level when implementing VEMPs. Many of the clinical equipment use a variation of intensity level known as dB-NHL, or normalized hearing level. So it is important to know what the underlying dB peak SPL is, because that'll kind of give you the ultimate understanding about whether or not you are stimulating at the correct intensity level. But I think this roughly translates to about 90 or 95 dB NHL. Muscle activation is a very, very big consideration in VEMP testing, and does need to sort of be considered when, especially when interpreting the results. Now, you could have too high, you can have an influence of high electromyography or muscle activity, or you can have influence of low muscle activity. They sort of affect the response in two different ways. So this is primarily concerned or related to cervical or CVEMP testing, um, since it's well known that the amplitude of that response sort of uh, is positively correlated to the amounts of muscle contraction there is, or that the patient is generating. And so if you do if you do have too low of a muscle contraction, it's definitely going to affect the underlying peak-to-peak amplitude of that response. On the flip side, if there is too high of a muscle contraction there, there's been studies that show that that can sort of artificially create an asymmetry if there is a difference in muscle contraction between the right and left ears. So it's just something to be aware of when you are actually measuring that response. Number of sweeps. I previously mentioned that 1 to 200 repetitions is pretty conventional. As long as pretty much you just want to at least have about 80, just to kind of bring out that signal, because the signal does jump around a bit at the start of the recording, or in the early phase of repetition. There are many different ways to calculate the underlying muscle contraction for CVEMP specifically. The one you sort of want to avoid is calculating the EMG average or EMG activation on that final average of the recording. Because of signal averaging, it's going to affect what value you're ultimately obtaining from that. So it's pretty conventional to sort of create, to get a mean rectified EMG average for each individual sweep, and then taking the average of that across all of your repetitions. And lastly, this one particularly relates to ocular VEMPs. So you just want to be aware of the gaze angle. So similar to the muscle contraction of CVEMPs, for ocular VEMPs, we know that the peak-to-peak amplitude is positively correlated with the degree that the eyes are gazed upward. And so if you don't have a target that is at least about 30 degrees up gaze in front of the patient, that could result in a reduced OVEMP. So just something to be mindful of. About 30 to 35 degree gaze angle upward is pretty standard, but not reaching that will affect, especially if the up gaze is different between sides. So now that we've discussed sort of a basic overview of VEMPs, we've discussed some of the common pitfalls and some of the things that can affect what you're looking at or affect the interpretation of the response. We're now going to discuss a little bit about the clinical utility of both cervical VEMPs and ocular VEMPs, and sort of how they're overall implemented or integrated into vestibular testing. So first and foremost, VEMPs should really never be used in isolation. They should be combined with other tests of vestibular function, tests of the semicircular canal function. Should really complement. VEMPs are really there to complement other vestibular testing. Hearing status or auditory function should also be considered, simply because most of the VEMP testing that is performed today is done through air conduction. And so you want to make sure that there is no middle ear pathology or any type of conductive hearing loss, because greater than, a airborne gap of greater than 10 dB could very well influence the response and decrease the sound pressure level that arrives at the otolith organs. And so just want to be aware that conductive hearing losses can affect air conducted VEMPs. And so that is one of the reasons why perhaps you may want to start looking at implementing bone conducted VEMPs, especially in children. It doesn't require as intense of a signal, and you can also bypass some of those middle ear issues. So it's bone conducted VEMPs have a lot of advantages, but I would say, definitely most common that you'll see out there is air conduction for sure. So some of the clinical utility basically comes down to three different things. It's used to, of course, assess otolith organs and their function. And basically these tests are going to be sensitive to any damage to those otolith organs or their underlying pathways. So anywhere along that vestibular nerve or central vestibular pathways, that central integration that underlines those reflex pathways, such as we see in Meniere's disease, neuritis, schwannomas, possibly some vestibular migraine, which we'll kind of briefly talk about as well. VEMPs are also used very heavily to detect enhancement of otolith activation by either sound or vibration. And so, such as in third window disorders like semicircular canal dehiscence. And so this is a very nice way to sort of screen for third window issues, and we'll talk about some of the research that's been done on that, as well as present some case studies as well. VEMPs have also been shown to be sensitive to slowing of conduction, so latency or prolonged latency delays along those neural pathways that are seen in some kind of central disorders such as MS. However, just want to caution the interpretation on that because latency differences can be due to sometimes technical factors. So as I mentioned earlier, any abnormalities that you do find on VEMPs should really be taken in the context of other vestibular testing, as well as if you're using air conducted VEMPs, auditory testing as well. So reduced or absent VEMPs are really common in vestibular disorders that affect sort of that peripheral end organ or that peripheral vestibular nerve, such as neuritis. Taylor et al. In 2016 found that neuritis specifically resulted in an absent OVEMP 70%, about 70% of the time, and 40% of the time in when measuring CVEMs. It's also been shown across a couple of different studies now that reduced or absent VEMPs are also observed in central brainstem lesions. So anything affecting those central pathways as well can also affect the generation of this myogenic potential. So diving into a condition like Meniere's disease, research has shown that about 30 to 50% of patients with Meniere's disease demonstrate an asymmetric CVEMP or OVEMP. Particularly, what is also interesting is that bone conducted VEMPs seem to be spared. At least one study has shown this, and so they've proposed that the stapes foot plate, or the effects of endolymphatic hydrops on the stapes foot plate seems to have a negative impact on air conducted VEMPs. And so another potential advantage of using bone conducted VEMPs in certain clinical populations. So this figure does come from that Taylor article, and just also um, displays what is also kind of becoming well known about Meniere's disease specifically, are these frequency tuning changes that seem to occur more in CVEMPs, but also appears in OVEMPs as well. And so I'm going to just sit here and kind of orient you to what we're actually looking at. But on the left, we have CVEMP corrected amplitude. On the right, we have OVEMP amplitude. And on the x-axis for both of these little figures is frequency, so from low to high. So just focusing here on CVEMPs for a moment. We have 4 different lines, one being the controls, one being patients with vestibular migraine, one being Meniere's disease, the affected ear, and then Meniere's disease, the unaffected ear. And so normally, and this kind of alludes to what I've pointed to earlier, is that we know that VEMPs and the otolith organs are most responsive to low frequency stimulation. And that's kind of where we expect our largest peak-to-peak amplitudes to occur. And so certainly for CVEMPs, we see that where we have our high peak-to-peak amplitude there at 250 and 500. And then above that, things kind of drop off. And so we start to see a decline in that peak-to-peak amplitude. But what is most interesting is that in the affected ear, the ear that's been diagnosed with Meniere's disease, we sort of see this broadening of frequency. And so we can see this this increase kind of in basically this broadening of frequency. And so we can see that the highest peak-to-peak amplitude in that affected ear is actually coming from 1,000 hertz, which we know in a normally working system, the otoliths are not going to be sort of responsible for. And this has really been attributed to some of the effects that, that some of the physical effects caused from these endolymphatic hydrops. On the right, it's not as pronounced, but you still see the highest peak-to-peak amplitude here at 1,000 hertz, when we would expect our highest peak-to-peak amplitude to either be 250, especially 500 hertz for an air-conducted VEMP. But we just don't see that in the ears that have been diagnosed with Meniere's disease. And so something that alluding to a potential biomarker here, but so there's been a few studies that have shown this broad frequency response compared to normal controls. So now we're going to switch gears a little bit and talk about vestibular migraine. This is probably one of the most common disorders that you'll come in contact with, in a specialized dizzy clinic. And when we talk about vestibular migraine and VEMPs, the pattern here is a bit interesting. And so reduced or absent OVEMP responses have been reported in patients with vestibular migraine in the presence of normal saccular function that's been kind of documented with some work that's been going on here, as well as a few other different sites, retrospective studies. What we also see is that basically the literature supports unilateral otolith impairment affecting postural stability as well. There have been cases of rotary vertigo at the onset of the impairment, and has been true for both saccule and utricle impairments. So how do we interpret any type of isolated otolith impairment? Well, we know that no replicable responses were obtained from the right and left ear, which suggests that impairment of that particular end organ. Um, Essentially, kind of going back to that fundamental use of VEMPs is you want to be able to correlate these results with the other patient's history as well as symptoms. Um, and overall, just what's the other vestibular testing telling you? So put this into context with everything else. Vestibular rehabilitation therapy has also been shown to be helpful in some cases of vestibular migraine. So if you do have this and the patient is symptomatic, it's not a bad idea to go ahead and make that recommendation because there is some literature to support that it is beneficial for some patients. Um, Here are just a few studies that have shown um, this unilateral or this OVEMP either bilaterally absent or asymmetry. Um, and what you can see is in patients with these are patients being tested, all of them having vestibular migraine or being diagnosed with vestibular migraine. And what you can see is most often most of the time what is absent is this OVEMP, either this asymmetric OVEMP or a completely absent OVEMP. Um, is what is being documented most of the time, but you can also see just the wide variability in and of itself compared to everything else, and it really could be depend on the timing of this migraine activity, any type of other co-occurring vestibular disorders as well. But again, just something very interesting that has been documented in multiple studies. This particular study by Young um, et al. In 2021 kind of shows a wide variety of different tests on that x-axis there, and the percent of time that they were either normal, asymmetric, or bilaterally absent. And what is interesting is for an error-conducted OVEMP, it was really only normal 65% of the time, um, absent 6% of the time, and or abs sorry, it was asymmetric about 15% of the time and bilaterally absent about 17% of the time. And so we're seeing these cases of OVEMPs or abnormal OVEMPs and patients with vestibular migraine. Uh, so this is going back to the study that was done here, but basically, essentially, those with normal CVEMPs and an abnormal OVEMP were about 87 times more likely to be diagnosed with vestibular migraine. So it's pretty clear that this special or particular relationship exists in this population. However, we don't necessarily understand the underlying pathophysiology at this point. Why this is happening, why this relationship between utricle function and migraine is not fully yet understood. Now we're going to get into one of the other main reasons why you may use VEMP testing or some sort of implement VEMP testing into your test battery, and that's for the use of VEMPs to detect or screen for semicircular canal dehiscence or SCD. Um, this has been shown time and time again. Um, this particular figure that I'm showing you is from Govender et al. In 2016, which was a really great paper that showed just the vast differences of VEMP responses in someone with a third window disorder compared to normal controls. And so that top row is going to be CVEMPs, that bottom row is going to be OVEMPs, and we're basically um, have either corrected amplitude or raw amplitude on that y-axis, and this is going to be across dB peak SPL. And so that gray shaded region or that left column is going to be air conduction, that right column is going to be bone conduction. So you really get a comprehensive view of VEMP responses in one figure. So what you can see is that gray shaded region is basically the amplitude intensity function for CVEMPs in a normal control population. So starting from about 105 all the way up to 130, 135, and you can see how that amplitude grows as you increase that intensity level. And so that is absolutely expected. But for all of these different patients, patient 1 through 13, you can just see how much larger those responses are compared to the normal controls. It's going beyond what we would, going beyond that range of normal, at least in this paper. And you can see that you're getting just a huge amount of amplitude at all of these different intensity levels. And what you're also noticing is that you're getting responses where you typically wouldn't necessarily expect a response. And so the initiation or the activation of that reflex pathway is being activated at a much lower intensity than what we would expect. We would expect a threshold around 105, 105 dB peak SPL, which would equate to about 70 dB NHL. And but in these patients with SCD, we're getting a much lower threshold, all the way down to 85, 90 in some cases. This same trend is happening both across air conduction and bone conduction. And it's also happening across both CVEMPs and OVEMPs. So we're really getting an enhancement all the way around across, across the utricle, across the saccule, and resulting in some really large responses. And so again, this course sort of speaks to that enhancement of otolith activation, just generated by that third window being there. And this is really just another way of looking at it, but you can see the slope of that amplitude intensity function really doesn't change in patients with SCD. Patients with SCD are kind of represented across the black line, normal control across that gray line underneath. And you can see in a normal system, we're getting sort of a gradual slope upward as you increase that intensity level, but not necessarily with patients in the presence of a third window. It's sort of the amplitude is large, and then it kind of just stays large as you increase that intensity. So it results in this maximum activation of these otoliths. And so in addition to these threshold changes that occur in VEMPs, Manzari and colleagues in 2013 found an interesting observation in patients with SCD when measuring OVEMP specifically. And what they found were these broad changes in frequency tuning. So similar to some of the changes that I mentioned in some other clinical populations, such as Meniere's disease, but this is an even more drastic change that has been observed in OVEMPs in patients with SCD, particularly when stimulating using a 4,000 hertz tone burst. And so what you can see here on this figure from that article is on the left, we have bone conducted vibration. On the right, we have air conduction. And we have our VEMP responses highlighted all the way down. This is an average, grand average across all patients with SCD. And what you can see is that your VEMP, this is an OVEMP, and what your OVEMP isn't necessarily changing or isn't decreasing with higher frequencies of stimulation. In a normal system, we would absolutely expect that, just based on the previous literature that I've presented here today, is, we know that the otoliths are most responsive at a lower frequency, and as that frequency increases, um, the sort of response or the system is no longer activating. But in someone with SCD, we're seeing still a pretty robust response at even 4,000 hertz. And so that's been more or less documented for the past, almost 10 years now. And so in addition to the threshold search that one might do to screen for um, SCD, um, that threshold search in a CVEMP, one might also add a 4,000 hertz OVEMP at about 125 dB peak SPL to see if there's any evidence of a third window. Some studies have suggested that a 4,000 hertz OVEMP is more sensitive than a threshold CVEMP. And I want to say the sensitivity is somewhere around between 80 to 90% of the time. We would certainly, in a normal system, not expect an OVEMP at 4,000 hertz at 125 dB peak SPL, but in someone with SCD, if you do see that, it's pretty telling and could be a convincing reason to recommend further imaging, or it could be indicate a positive screening for some type of third window if there is one present at that frequency. And here's an interesting figure by Tran et al. In 2020 showing SCD, or comparing SCD patients to a population of healthy controls across different age groups. And so even across age, we can see that there is a pretty stark difference between those with SCD and healthy controls when kind of implementing this 4,000 hertz OVEMP. It's the change is more obvious at patients younger than about 60, but it's still there even in patients with even in patients who are older than 60, all the way on the right there. And so even though we know that aging certainly impacts the VEMPs, if you do have an OVEMP, it's certainly still, an OVEMP at 4,000 hertz is still pretty clear sign that a potential third window issue is going on, or some type of third window problem is there. And so this is just another, interesting demonstration of how a 4,000 OVEMP could be implemented into a clinical protocol. So now we're going to get into some of our case studies and sort of bring a lot of things together, and then hopefully you can see how these VEMPs are kind of implemented and integrated into the broader test battery. So this is a 69-year-old female evaluated in 2010. She's had dizziness for 2 years, episodes lasting anywhere from 15 seconds to 15 minutes, about 1 to 2 times every 2 to 3 months, described as fuzziness, disequilibrium, headaches, often associated with the dizziness, and the MRI was normal. And so this is a look at the audiogram here, pretty, other than the sensory neural hearing loss, no major, conductive components, severe high frequency hearing loss with a word recognition score of 90% bilaterally. These are some of the results of the balance function tests. VNG was normal, only a 5% caloric asymmetry between the ears, which is not significant. We also see a normal rotational chair, so had normal phase gain and symmetry measures, and fixation suppression was intact. Now, these are the results of the CVEMPs that were performed. You can see on the left, we have a 337 microvolt response compared to about 132 microvolt response on the right. About a 44% asymmetry, which in our clinic was not significant. We actually looked for about 47%. However, when we did screen for that CVEMP threshold, we found a 65 dB NHL threshold compared to a 95 dB NHL on the right. And usually we like to see a CVEMP threshold greater than 70 dB NHL, which again correlates to right around 105 dB peak SPL. And so this was actually a positive screening for SCD. Now, if we take a look at the OVEMPs, what we can see is a 42 microvolt OVEMP on the left and about a 7 microvolt OVEMP on the right. Now, anyone performing OVEMPs currently kind of looks at that amplitude response and thinks, wow, because that is a large, very large OVEMP. It actually resulted in a pretty significant asymmetry between the ears, about 70%. So just strictly looking at this at these responses, you would think, whoa, is something going there on the right? Is it not functioning as well as it should be? But again, in cases of SCD, this is actually presenting as an enhancement of the left response. The issue is on the left, not necessarily the right, and that's just because that those otolith organs are being activated at a much lower intensity, and just based on some of the work that I've showed you that was done by Govender and colleagues in SCD, you can see that once those otoliths are activated, that there's really no change in that peak-to-peak amplitude no matter how low you go. So yeah, in this case, it would be more of an enhancement, not necessarily a weakness in OVEMPs. So patient was referred for a CT scan of the temporal bones and found a dehiscence on the left superior semicircular canal. This is just a second case of a 65-year-old female in 2013, presented with BPPV-like symptoms for 3 weeks, long-standing history of hearing loss. She did sustain a head injury in 1998. She came in with an outside diagnosis of Meniere's disease and had some surgical procedures done for that. Denied any pulsatile tinnitus, vertigo with loud noises, oscillopsia, anything like that. And this is the audiogram, so pretty, nothing really, just like the previous case, nothing really surprising there. Mild to severe high frequency hearing loss bilaterally with 100% bilateral word recognition score. VNG was abnormal. It did show left posterior semicircular canal BPPV, more or less intact low frequency VOR function as determined by calorics. And what we can also see here are the VEMP results. So we can see on the left, we have a 94 microvolt response compared to a 188 microvolt response on the right. That was a 33% asymmetry, which is not abnormal, so that is completely normal. We did have a CVEMP threshold on the right at 65. Left was well over 70 dB, so a little concerning for that right side. When we did the OVEMPs, you could see, again, that enhancement of that right side, 21 microvolt response compared to 6 So immediately, just if this wasn't taken into consideration with the patient's case history or symptoms or other test results, you may be thinking that that left side is weaker because everything is all relative. But in this case, this is actually an enhancement. And again, referred to for a CT scan and found a dehiscence on that right superior semicircular canal, which was described as a thinning um, rather than a pure dehiscence. Um, so yeah, just another way that we can see SCD show up on some of our tests. So I hope I was able to provide a good foundation for how VEMPs are used um, currently and how they complement the standard vestibular test battery in a variety of different vestibular disorders. And so hopefully a lot of your questions have been answered. Um, but we're also going to talk, I just wanted to briefly bring into some of the work that I'm currently doing to kind of bring another potential use of um, VEMPs, more or less into screening protocols. And so we know, I had showed this slide earlier, we know that there are a lot of different ways that VEMPs can affect, or there are a lot of different things that can affect the VEMP response. One of them being muscle contraction, other being a low signal to noise ratio, maybe through added background noise. We know that aging affects these responses, and so sometimes it can make visual detection a little bit difficult, especially when trying to either find threshold or when there's a lot of noise present. Um, and so what some of my work also looks at is there an alternative to visual detection of the response? And what we're showing is potentially. Um, so there's an algorithm out there known as fixed single point. It was developed in 1984 to objectively detect the ABR. It essentially calculates the variability of both a, a, a window determined to be the signal and compares it to a single point in time that is supposed to represent a noise estimate. If these estimates follow an F distribution, and it basically uses an F test to determine if the response is present. So rather than visually detect the response, it uses some type of statistical measure to detect the response. And the ratio between our expected signal and the single point in time is essentially known as FSP. This also serves as a measure of signal to noise ratio. This algorithm has multiple clinical applications, and it also played a critical role in newborn hearing screening programs back when these were being developed. So the calculation of this algorithm is really straightforward. It just uses it has a specific time window that's predetermined where you basically expect that response to occur, and that's going to be defined as your signal. And then it divides that estimate of that, or that variance, by a single point in time. This point in time can be either before or after stimulus onset. And so again, that just uses, or that kind of follows into what FSP actually is. Um, this calculation is performed across blocks of sweep, so it's performed across every repetition that you take. And so because if a because we expect our signal to be there, if it actually truly is, its variance will not change across multiple repetitions. So as many repetitions as you take, as many times as you deliver that signal, you're going to expect that variance to be the same if the signal's actually there across that predetermined time window. That's a little bit different from our noise estimate, as we know with signal averaging, we know that the more sweeps or repetitions that we take, the more that noise is going to decrease over time. And so we expect its variance to decrease with increasing number of sweeps. And essentially what ends up happening is we get this growth of FSP as more sweeps are taken. And we then see, again, this growth as more and more sweeps. We then calculate sort of a predetermined criteria. If the FSP ratio crosses or surpasses that criteria, we determine the response to be present. If it doesn't, if it never crosses that criteria, we determine it not to be present. So that's essentially how FSP functions. And we've modified this algorithm to for VEMP detection. So very briefly, I'm going to talk about just the technical specifications. So for CVEMPs and NoVEMPs, we chose a -2 millisecond noise estimate just based on some of the preliminary work that we've done. We had a time window for CVEMPs from 10 to 30 milliseconds, and an OVEMP time window from about 8 to 25 milliseconds. And so the final value that I'll be showing here is the final FSP value at 128 sweeps. So this is just a brief overview of how we calculated that FSP criteria level. What level did FSP need to surpass in order to be present? And what we did was we essentially just took our normal time window where we expected the response to be, and we shifted it to the pre-stimulus period to create a noise-only condition. So we wanted to determine what is the highest percent or 99th percentile of an FSP value when we knew the response was not there, and that's how we essentially determined what was the highest FSP value with 99% confidence, and that became our FSP criteria value. So if any value surpassed that, we essentially then could determine that the response was there. So here's some data for 2 individual subjects. I have figures that basically show FSP as a function of sweeps or trials. Down below, we have waveforms across sweeps as well. And what we can see is, so the bottom portion of that figure is what we're most familiar looking at, right? So we start out with a wave or a more noisy waveform at the earlier sweeps, and as we take more sweeps, that waveform kind of cleans up. Well, if we look at FSP in response to that, it's growing as well as we take that increased number of averages. And the same thing pretty much happens with OVEMPs as well. Now, what is interesting and what you might notice here, that gray little line, dashed line in the top portion of the figure is the FSP criteria value. So that's the line that FSP needed to cross in order to become present. And what you can see is that for most of these, we're having present responses right around 8 to 16 sweeps. So FSP is really fast at determining whether the response is actually there. And this happens for really both subjects, except for the subject number 2. Their CVEMP crosses right around 48 or 56, and that's just because they had and you can visually see how much smaller their waveforms were compared to subject 1. So what would this mean clinically? FSP is already in clinical equipment. So if we can show that this algorithm also works for VEMPs, the transition to clinical practice would be pretty straightforward and a pretty easy transition. There are still several stimulus and recording parameters that need to be investigated. So how does it perform across stimulus level, EMG activation, gaze angle, a lot of these different things. So a lot of that has to be kind of worked out before any clinical use, but it could be useful in more real-world scenarios. So it could shorten the test time, or in patients who are unable to generate or sustain a high or large amount of muscle contraction. It could also help them. children at risk for noise exposure. Again, shortening that test time may be useful. And then kind of the larger goal for this is to kind of use this algorithm to implement potentially an infant vestibular screening protocol. So pretty exciting stuff to look forward to here. And thank you very much, and I'll answer any questions. I appreciate everyone's time.